Welcome, curious minds, to the deep dive. Today we're embarking on a really fascinating journey into pharmacology. That's the science behind how drugs actually work in our bodies. You've handed us a great stack of sources, things like drug classification, terminology, and pharmacokinetics, right through to medical essentials, vitamins, drugs, and immunity. Our mission, to really distill those pages, pull out the key insights for you.
Absolutely. We'll be uncovering the fundamental principles, the rules that govern everything from how, say, a simple pain reliever works to the really complex stuff, the life-saving medications. Get ready for some real aha moments, I think.
Okay, let's unpack this then. We're focusing on understanding what a drug is, fundamentally, where they come from, and then that incredible dance they do once they actually enter your system. It's quite a journey. So let's kick off right at the beginning. What, in a scientific sense, is a drug?
Well, at its absolute core, a drug is basically any chemical substance that, when you introduce it into a living organism, it modifies one or more of its physiological functions. Think about paracetamol, right? It lowers your fever because it acts on a specific part of the brain, the heat regulating center. It's like a chemical signal changing a biological process.
That makes sense. A chemical key, kind of.
Yeah.
So where do these powerful substances, these keys, even come from? It's not always just a lab, is it?
No, you're absolutely right. Drugs have really diverse origins. Some are natural. Think morphine from the opium poppy, or insulin, which historically actually came from pigs. Then you have synthetic or semi-synthetic. These are the ones made or modified in labs. Common ones like aspirin or amoxicillin, the antibiotic. And now, increasingly, biotechnology products. These are, modern marvels. Things like monoclonal antibodies or the recombinant insulin we use today. Much more complex molecules.
That's quite a range, from poppies to biotech labs.
Yeah.
So once we have the drug, how does it actually get into our system to start doing its job? We know there are different ways, different routes.
Right, and this raises a key question. Why so many routes? It's not random. It's really about the effect you want, how fast you need it to work, and, the patient's condition. Can they even swallow a pill? So you have the enteral routes, that's via the digestive tract. Oral is the most common, like taking an ibuprofen tablet. Convenient, right? But it has to survive the gut. Then there's sublingual, under the tongue, like nitroglycerin for angina.
Oh, yeah, for speed.
Exactly. It gets absorbed super fast, directly into the blood, and crucially, it bypasses the liver initially. It's a shortcut. You also have rectal, which is useful if someone can't take drugs orally, maybe they're vomiting. Then there are the parenteral routes. These are injections basically bypassing the gut. Intravenous goes straight into the vein, immediate effect. Think IV antibiotics like ceftriaxone when speed is critical. Intramuscular, IM, is into the muscle. It's slower than IV, but usually faster than taking a pill, like vaccines. And subcutaneous, SC, just under the skin, that gives a slow, steady absorption. Insulin is often given this way. Plus, you've got inhalational for lung drugs, like salbutamol for asthma.
Right, directly to the target.
And topical, of course, creams or things applied right onto the skin or mucous membranes.
Okay, so the drug is in. Now, this is where our sources get really interesting. They talk about something called ADME. What does that actually stand for, and why is it so fundamental to understanding how medicines work?
ADME. Yeah, it stands for absorption, distribution, metabolism, and excretion. This whole sequence is what we call pharmacokinetics, which is basically what the body does to the drug. It's the drug's entire journey, start to finish.
Okay, let's break that down. First up, absorption.
Right, absorption. This is the drug's journey from where you administered it, maybe the stomach, maybe under the skin into the bloodstream. It's crossing that first barrier. Several things affect this. How lipid soluble is the drug? Things like diazepam, which dissolve well in fats, tend to cross membranes faster. pH is also a big factor. Weak acids, like aspirin, tend to be absorbed better in the acidic environment of the stomach. Weak bases, like morphine, prefer the more alkaline intestine.
Huh, I never knew that.
Yeah, and even the formulation makes a difference. A liquid syrup will usually absorb faster than a solid tablet. And here's a really practical point food can interfere. You know how some drugs say, take with food, and others on an empty stomach?
Yeah, always wondered why.
Well, sometimes food helps, sometimes it hinders. Like milk can really reduce tetracycline absorption because the calcium binds to the drug. It actually stops it from getting absorbed properly.
Wow, so those instructions are really important then, not just suggestions.
Absolutely crucial for the drug to work as intended.
Okay, so it's absorbed, it's in the bloodstream. What happens next?
Distribution. This is how the drug spreads out from the blood into the body's tissues and organs. Organs with a really good blood supply, think the liver, kidneys, brain, they tend to get more of the drug and faster. Makes sense, right? More traffic goes there.
Right.
Then there's something called plasma protein binding. A lot of drugs, once they're in the blood, latch onto proteins, especially one called albumin. Warfarin, the blood thinner, is a classic example. About 97% of it binds to albumin.
97%.
Yeah. And here's the key thing. Only the drug that's not bound the free drug is actually active. The bound part is like a reservoir, releasing the drug slowly.
Okay, so the binding percentage really matters.
Hugely. And then you have specific barriers. Your body has gatekeepers. The blood-brain barrier, the BBB, is famous. It protects the brain. Lipid-soluble drugs like benzodiazepines can get through, but water-soluble ones like penicillin generally can't.
Which is good, mostly.
Usually, yes. And similarly, the placental barrier protects a fetus, but it's not foolproof. Some drugs, like alcohol or, tragically, thalidomide, can cross and cause harm.
So it gets in, it spreads out, but it faces these hurdles and binding issues. What's next in ADME? M for metabolism.
Exactly. Metabolism, or sometimes called biotransformation, this is where the body chemically changes the drug. It mainly happens in the liver. You can think of the liver as the body's main chemical processing plant. The main goal usually is to make the drug more water-soluble. Why? So it's easier for the kidneys to get rid of it later.
Preparing it for exit.
Precisely. It often happens in 2 steps, or phases. Phase I involves reactions like oxidation, reduction, hydrolysis. It often uses a big family of enzymes called the cytochrome P450 system, CYP450.
I've heard of that. Isn't that affected by grapefruit?
That's the one. Grapefruit juice can inhibit some CYP450 enzymes, which messes with the metabolism of certain drugs. It's a real interaction. Sometimes phase I actually turns an inactive drug into an active one, or makes an active drug even more active, like diazepam gets metabolized into another active form. Then comes phase II. This is usually conjugation. The body sticks a larger water-loving molecule onto the drug or its phase I metabolite, like adding glucuronic acid. This makes it much more water-soluble and usually less toxic, ready for excretion. Paracetamol goes through this, forming glucuronide conjugates.
Okay, so phase I modifies it, phase II packages it up for removal.
That's a good way to think about it. And there's a cool concept here called prodrugs. Some drugs, like enalapril for blood pressure, are given in an inactive form. They only become active after the liver metabolizes them in phase I. It's a clever trick.
Why do that?
Sometimes it helps with absorption or getting the drug to the right place before it switches on.
Fascinating. Okay, so it's been absorbed, distributed, metabolized. The last letter is E. Excretion.
Excretion. Getting rid of it, eliminating the drug or its metabolites from the body. The main route by far is the kidneys, filtering waste from the blood into urine. Many antibiotics, like aminoglycosides, rely heavily on kidney excretion.
So kidney health is vital here.
Absolutely critical. If your kidneys aren't working well, drugs that are cleared that way can build up to toxic levels. Dose adjustments are often needed, but there are other routes too. Some drugs leave in bile, produced by the liver, and exit in feces. Rifampicin is an example. Volatile gases, like some general anesthetics, halothane was one, are exhaled through the lungs. And tiny amounts can leave in sweat, saliva, even breast milk, which is important for nursing mothers. And just like absorption, factors influence excretion. We mentioned kidney function. Age is another influence, and the elderly often excrete drugs more slowly. And interestingly, we can sometimes manipulate excretion. In certain poisonings, like with phenobarbital, making the urine more alkaline actually speeds up the drug's removal by the kidneys. It's a treatment strategy.
Wow, that ADME journey is incredibly complex, but you've made it really clear. It's not just take pill, feel better. So, given all this, how do we even start to categorize drugs? There must be thousands. And what are the key terms we need to grasp?
Yeah, classification is important for making sense of it all. One really useful way is based on their action. Are they selective or general? Selective action means the drug targets a very specific receptor or enzyme, or maybe just one organ system. It's like a sniper rifle. Think of atenolol for high blood pressure. It mainly blocks beta-1 receptors in the heart. Or salbutamol for asthma, targeting beta-2 receptors in the lungs. Omeprazole hits the proton pumps in the stomach. The goal is maximum effect where you want it, minimum elsewhere.
Precision medicine, basically.
Exactly. Then you have general action. These are more like shotguns. They affect multiple systems or tissues quite broadly. General anesthetics, like halothane used to, depress the entire central nervous system. Alcohol affects many different organs. Steroids have widespread anti-inflammatory effects all over the body.
That selective versus general distinction really helps. What other ways do we classify them?
Oh, several ways. Sometimes by pharmacological action, what they do. Analgesics relieve pain, paracetamol. Antipyretics reduce fever. ibuprofen, sometimes by chemical structure. Like beta-lactam antibiotics, they all share a similar chemical ring structure, like penicillin, or by therapeutic, use what condition they treat. Antihypertensives treat high blood pressure, atenolol again. And sometimes, just for reference, alphabetically, though that doesn't tell you much about the drug itself.
Okay, lots of labels. Now, terminology. Our sources are full of specific words. What are the absolute must-knows?
Right, knowing the lingo is key. Here are some crucial ones. Agonist. This is a drug that binds to a receptor and activates it, producing a response. Like adrenaline making your heart beat faster, it turns the lock. Antagonist, this binds to the receptor but blocks it. It sits in the lock and prevents the key, like adrenaline, from working. Propranolol is a beta blocker and antagonist.
Okay, agonist activates, antagonist blocks.
Precisely. Then there's partial agonist. This one binds and activates but only gives a partial response, even if all receptors are filled. Buprenorphine for pain is like this some effect, but maybe less risk than a full agonist. Potency. This is about how much drug you need for an effect. Fentanyl is way more potent than morphine. You need a tiny dose for the same pain relief. Efficacy. This is about the maximum possible effect. Morphine has higher efficacy for severe pain than aspirin. No matter how much aspirin you take, it won't match morphine's peak effect.
So potency is dose, efficacy is max effect.
You got it. Then, therapeutic index, TI. Super important for safety. It's the ratio between the toxic dose and the effective dose. A high TI means there's a big gap between the dose that works and the dose that causes harm. Penicillin has a high TI, it's relatively safe. A low TI means that gap is narrow. Digoxin for the heart has a low TI. You need a very careful dosing and monitoring. It's about the wiggle room.
That makes sense. Less room for error with a low TI.
Exactly. Then bioavailability, we touched on this. It's the fraction of the administered drug that actually reaches your systemic circulation unchanged. 40 is 100%. Oral is often less because of absorption issues or that first pass effect. Half-life, T high. This is the time it takes for the drug concentration in your plasma to drop by half. It tells you how long the drug sticks around. Diazepam has a long half-life, maybe 30 to 60 hours.
So that dictates how often you need to take it.
Right. First pass effect, we mentioned this too. Oral drugs go through the liver first via the portal vein. The liver might metabolize a lot of it before it even gets to the rest of the body. This reduces bioavailability. Nitroglycerin under the tongue avoids this. And finally, potentiation. This is when one drug increases the effect of another. The classic dangerous example is alcohol. And sedatives, alcohol makes the sedative effect much stronger.
That's a fantastic glossary. Therapeutic index, half-life, first pass. Really crucial concepts. But what happens when things go wrong? When drugs don't act as planned or cause harm? Our sources mention allergy, idiosyncrasy, toxicity.
Yes, this is the other side of the coin, adverse drug reactions. Drug allergy is an immune system reaction. It's abnormal, it's immune-mediated, and it's not related to the normal dose. Your body mistakenly attacks the drug. Type I is immediate, sometimes severe. Anaphylaxis from penicillin is the nightmare scenario. Urticaria, hives, type 5e is delayed. Often skin reactions like contact dermatitis or rashes appearing days later. This is why asking, are you allergic to anything, is the first question. Then there's idiosyncrasy. This isn't an allergy, it's an unusual, unexpected reaction in a specific individual, usually due to their unique genetics or metabolism. The example often used is Primakine, an anti-malarial. In people with a specific enzyme deficiency, G6PD deficiency, it can cause their red blood cells to break down. It only happens in those susceptible individuals.
So it's genetic, not immune.
Right. And finally, drug toxicity. This is dose-related. It's harm caused by too much drug, either a single large dose or accumulation over time. Acute toxicity is from a single overdose. Paracetamol overdose causing liver failure is a stark example. Or morphine overdose stopping breathing. Chronic toxicity develops from long-term use, like osteoporosis from prolonged high-dose steroid use. And sometimes toxicity is organ-specific. Certain antibiotics, like aminoglycosides, are known to be potentially damaging to the kidneys, hepatotoxicity. The TB drug isoniazid can harm the liver, hepatotoxicity.
Managing toxicity.
Stop the drug, that's step one. Sometimes there are specific antidotes like N-acetylcysteine for paracetamol poisoning. Otherwise, it's supportive care managing the symptoms.
This really underscores the importance of using drugs correctly. Let's zoom in now on some specific drug categories from our sources. The endocrine system. Hormones. That sounds like a delicate area to meddle with.
Oh, incredibly delicate. Hormones are powerful messengers, so drugs affecting the endocrine system need careful handling. We have hormone replacement therapy, giving back what's missing. Insulin for type 1 diabetes is the obvious one, various types. Rapid-acting like Lispro, long-acting like Glargine, or levothyroxine for an underactive thyroid. We also have hormone suppression, or antagonists, blocking hormones. Tamoxifen blocks estrogen receptors in some breast cancers. Mifepristone blocks progesterone. And then there are glucocorticoids, or corticosteroids, like prednisolone, dexamethasone, powerful anti-inflammatories used for asthma, arthritis, autoimmune diseases. But they come with a price. Long-term use has significant side effects: osteoporosis, thinning skin, increased infection risk. It's always a balance.
A real double-edged sword there. What about vitamins? We take them for health, but how do they fit pharmacologically?
Well, vitamins are essential organic compounds for metabolism. Usually we get them from diet, but when given in therapeutic doses for deficiencies, they act like drugs. We classify them mainly as fat-soluble vitamins A, D, E, K. These can be stored in body fat.
Which means you can overdose.
Exactly. Because they accumulate, you can get toxicity. Too much vitamin D can cause dangerously high calcium levels, hypercalcemia. Too much vitamin A can also be toxic. The others are water-soluble, the B-complex vitamins and vitamin C. Excess amounts are generally just peed out, so they're much safer in high doses. Each has a critical role: A for vision, D for calcium, K for blood clotting, C for collagen and wound healing. The B vitamins cover a whole range. B1 thiamine deficiency causes beriberi. B3 niacin deficiency causes pellagra. B12 deficiency causes pernicious anemia, so they're targeted treatments for specific deficiencies.
Good reminder that even natural things like vitamins can have dose-dependent effects. Okay, shifting to infections, antibiotics, and sulfa drugs. Big topic.
Huge. Antibiotics target bacteria. Key thing is how they work their mechanism. Some are cell wall inhibitors, penicillins like amoxicillin, cephalosporins like ceftriaxone. They break down the bacterial wall. Others inhibit protein synthesis. Stop the bacteria from making essential proteins. Macrolides like azithromycin, aminoglycosides like gentamicin fall here. Then you have nucleic acid inhibitors. They mess with the bacteria's DNA or RNA. Quinolones like ciprofloxacin, rifampicin, and folic acid synthesis inhibitors. Bacteria make their own folic acid, unlike us, so drugs like sulfonamides block that pathway. Sulfamethoxazole is one.
So many different ways to attack them.
Yeah, but adverse effects are common. Allergies, especially with penicillin, anything from a rash to anaphylaxis, diarrhea is frequent. And the biggest issue today, antibiotic resistance. Bacteria evolving to survive the drugs, driven by overuse and misuse. It's a massive public health threat.
A really critical point. And
Yeah.
sulfa drugs specifically.
Right. Sulfa drugs are those folic acid synthesis inhibitors. Sulfamethoxazole is often combined with trimethoprim, another drug hitting the same pathway, for things like UTIs. They have some specific potential problems, though. Serious skin reactions like Stevens-Johnson syndrome, though rare. Kidney stones or crystalluria, that's why you're told to drink plenty of water with them. And photosensitivity, making you prone to sunburn.
Okay, good to know those specifics. Our sources also briefly mentioned metabolic compounds, inorganic stuff, and immunological products. What are the highlights there?
Yeah, these are fundamental too. Inorganic compounds, electrolytes, things essential for body function. Magnesium sulfate used as a laxative, but also intravenously to prevent seizures and eclampsia. Sodium bicarbonate antacid also treats acidosis. Potassium chloride for low potassium. Calcium gluconate for low calcium. Ferrous sulfate for iron deficiency anemia. Basic building blocks or balancers. Chelating agents, these are interesting. They bind to toxic heavy metals like lead or excess iron, forming a compound the body can excrete. EDTA for lead poisoning. Deferoxamine for iron overload, like chemical claws grabbing the poison.
So that's clever.
It is. And finally, immunological products. These modulate the immune system, vaccines, of course. They stimulate your own immune system to build protection. Active immunity, hepatitis B, MMR, BCG vaccines, immunoglobulins. These provide passive immunity. You get ready-made antibodies from someone else. Gives immediate but temporary protection, like rabies immunoglobulin after a bite. And monoclonal antibodies. Highly specific, engineered antibodies targeting particular molecules used in cancer, autoimmune diseases, like infliximab for rheumatoid arthritis. Very targeted immunotherapy.
Wow. We have covered an incredible amount of ground, from the absolute basics of what a drug is through that whole ADME journey, classifications, key terms, what goes wrong, and then specific categories like hormones, vitamins, antibiotics. It's been a real deep dive into pharmacology.
It really has. And I think going through these sources highlights that drugs aren't magic. They're chemicals interacting with our biology in largely predictable ways based on these principles we've discussed. But there's also that individual variation, the potential for adverse effects. Understanding ADME, selectivity, half-life. It's all crucial for using them safely and effectively.
So what does this all mean for you listening? Well, the next time you take any medication, Maybe pause for a second. Think about that journey it's about to take inside you, from getting absorbed, distributed where it needs to go, processed by your liver, and finally making its exit. It's this intricate chemical choreography happening within your own body.
And maybe this raises a final thought or a question for you. In this world where we see new drugs, new therapies appearing all the time, how can understanding these core principles, absorption, metabolism, selectivity, toxicity, how can that empower you? How can it help you have better conversations with your doctor, ask sharper questions, and be a more informed partner